Hola, soy el doctor Francisco Osorio y hoy me encuentro aquí con el doctor y profesor Herman Tournaye y vamos a conversar un poco acerca de su trayectoria de la medicina reproductiva en Bélgica, cuáles son los puntos clave de las charlas que él nos brindó durante el congreso, algunas recomendaciones de él para los futuros urólogos andrólogos. I would like to thank you for your participation in the Chilean Urology Congress.
It's an honor and it's a pleasure to be here, so thank you also.
Professor Tournaye, could you briefly tell us about your career journey and how you became interested in the field of andrology and reproductive biology?
Let me tell you one secret. I'm an OBGYN, so I'm not a urologist by training, but when I was a medical student, I was always doing rotations in the department with the late Bob Schoisman. He was also a gynecologist, but a microsurgeon, and he had a great interest in male infertility. And when I joined the center in Brussels, my new boss, when I was a gynecologist, said, you were with him, so you should have an interest in reproductive andrology. You will have your focus on the male in our center. Mm-hmm. And that's the start, in fact.
Who do you think has most influenced your professional development?
Bob Schoisman, because he was the one that, in fact, introduced me to the andrology part. Because of that, my career was reproductive andrology.
Looking back, what do you consider the most significant milestones or breakthroughs in your career?
Personally, I think that the introduction of the intracytoplasmic sperm injection in our center was the real main breakthrough, although I was not really involved in the lab next door where Giampiero Palermo was developing the ICSI technique. I was trying to do something with pentoxifylline to improve the fertilization in traditional IVF. But I was the clinician looking after the man. So very quickly, I was involved in the clinical application of the ICSI technique.
And you were also one of the first ones using sperm from the testicle to do ICSI.
Sometimes in the early days, publication from the UK, the use of testicle sperm in men with obstructive azoospermias, post-vasectomy in fact. And eventually, I was doing the same. But sometimes you run into a patient with the wrong diagnosis. And in fact, it was an unobstructive one. But still, I did find sperm. And from that moment on, I started to do it on purpose. So every man that I saw with an azoospermia, small test, I said, come, let's try it. And eventually, the 95 publication is a small series, but it's still, there was a patient coming from New York, Jewish patient. I remember him like that. And it turned out when he was in Brussels, just in front of me in my office, that he had a Klinefelter syndrome. And I told him, look, Klinefelter, all the textbooks, we learned at medical school, sorry, we cannot help you. And I remember saying to him, hey, doc, I didn't come from New York all the way to hear you tell me that to me. So please give it a try. And I found sperm. And he had an FSH over 100 even. Incredible. Peanut-sized testicles. And I found sperm. Eventually, they never got a pregnancy. But the sperm was found. At least and from that moment on, again, you will start doing every Klinefelter. So let's give it a try. And indeed, in some cases, it was successful.
You also have been instrumental in advancing assisted reproductive techniques for male infertility. Which innovation are you most proud of?
Probably the prepubertal banking. So, when boys get treatment against cancer.
In the testis group that you run.
So at a certain moment, I got the green light from the ethical committee and they said, you are crazy, it will never work. To start banking testicular tissue from boys of 9 years old, for example, hoping.
Before chemotherapy?
Before any chemotherapy. And of course, in boys where the chemotherapy would be sterilizing. So that it was really a black and white situation. And now, December 2024, we did the first grafting of that tissue. And one of the patients that banked, in fact, when he was a boy of 8 years old, I think, he banked testicle tissue. And so now we are awaiting the result.
For many years, you have been the head of the department of one of the largest reproductive medicine centers in the world. So how does your center integrate clinical care with laboratory research and teaching in daily practice?
Basically, we are university-based, which means there's just a medical school next door. And so for the research, in fact, we work closely together with the whole research group. They have a unit on spermatogenesis, a unit on the ovary. And so there are different domains. And we always have a sort of binomium. That means that there is a head clinician always in touch with the head of a lab. So, for example, in my case, it's the reproductive andrology, the prepubertal banking, the Klinefelter story. It was also main let's say, main domains of research at university, together with Professor Kroeses now. And so we get along very well. And so that's the way we try to work it out, that you have a clinician in closely contact with a scientist for a certain domain. That works perfect, I think.
In the past 20 or 25 years, you had a lot of Chilean residents there, gynecologists, urologists.
Yeah.
What do you think about the level of reproductive medicine here in Chile?
Well, at least what I can say to start with, that we were always very happy to have Chilean colleagues, because all these Chilean doctors are well-trained, high level, high quality, so always welcome in Brussels. The level of what you can do here in Chile is also very high in the reproductive medicine.
How important for you is the multidisciplinary approach?
I think that in reproductive medicine, it's key. It's really the key to success. Sometimes patients come to me and they ask me, doctor, are you going to do the pickup? Are you going to do testicle biopsy? I say, no, sorry, I can only be good in one thing. It's a team effort. And the idea as the head of the department is to have at every stage of the treatment the best person. And so you need a team
to get the most of everyone. In the Congress, you gave us a very interesting lecture about the landscape of male infertility in 2025. What do you think? What can you tell us about the key points of that lecture?
That there is still a lot of gaps in our knowledge, and they keep on being a gap. For example, the prevalence of male infertility. Nobody really knows. Everybody's referring to papers of the 80s and the 90s, while in the meantime, maybe because of environmental factors, there is decline in male infertility. And so you would expect that it would be more prevalent than what the papers of 40 years ago tell us. On the other hand, is there really a decline? Big question mark too. It's still very controversial whether indeed there is a decline. And then for treatments, I'm afraid that the only thing that happened is IVF and ICSI, because all other types of treatments, maybe there are some treatments that may in the future be developed, but you see that patients themselves, they get older and they are really looking for a very quick treatment. Yes. Sometimes treatments, they may take years before they really give the results.
What key points can you tell us about your lecture, Klinefelter?
I was lucky to be the first to find sperm in a Klinefelter patient's testis. And then eventually also there we started in Brussels to bank prepubertal tissue and peripubertal tissue, because Klinefelter patients, they lose their stem cells when they go into puberty. The idea was maybe we can save them, freeze them, preserve them, and later on transplant them. Now, transplantation is not probably the best idea because of the sclerosis and the fibrosis. But now, in recent years, there is a group, in fact, it's a research from Iran, was trained. We worked together with him when he was in Amsterdam, and now he's in the US, and he's culturing the stem cells from Klinefelter patients. And although at this very moment, there are no others who could do the same, but he claims, and he published, that over time, he's doing the in vitro culture of the stem cells, the 47XXY, there is an increase in cells that are either X or Y bearing, so that they make errors in their mitosis in the good way. So maybe if eventually in the end you could really produce in vitro sperm cells from stem cells that again make sort of genetic correction in what way or another, in vitro, maybe that's something. So then you can argue that early in their childhood, maybe you should take indeed stem cells, bank them, preserve them for later in vitro cultures. But that's still a big question mark.
What advice would you give to young urologists or andrologists who are beginning their career in reproductive medicine?
Be open to your patients. If your patients have a good idea, jump on it, because as you can see, the Klinefelter story.
From your perspective, what key skills or mindsets should the next generation of specialists develop to treating male infertility?
Everybody has his own skills, but working together, because reproductive medicine, after all, in male infertility is the male, but also the female. So in fact, as a gynecologist, you should be aware of what's happening in the male and vice versa. So I think the skills for a urologist would also be try to understand what's happening in the man's wife, know everything about ovarian reserve, know everything about the impact of age, because there's such a crossover that you cannot just have a focus on one of the two partners alone.